Ryan Stanton here with ACEP Frontline, and joined by Dr. Jim Williams. We've actually, interestingly, every time we podcast has been right here within this 50 square foot area at the Grand Hyatt in Washington, D.C. for Leadership and Advocacy Conference. And we have you back today because last time we talked about the NOACs and anticoagulation related issues and what we have that can reverse it. And there's been some updates since we last chatted, so we wanted to get you back in here so we could talk about where are we now, because as you know, the NOACs, the novel oral anticoagulants, or whatever term you like to use for them now, are becoming more and more common in our practices. We're seeing them all over the place, whether it's the treatment of DVTs, PEs, prevention of stroke with AFib, whatever things there may be out there, we are seeing a ton of them. We are likely to see more of them, and the associated potential side effects in dealing with issues such as trauma while folks are on these. And so, I mean, it's almost become now with these medications, we're in that full pendulum swing that we almost always are with medications that have pretty significant benefit, but also the potential, the popularity has grown. We're now in that huge, when you're born, you get your vaccinations and you get your NOAC to prevent your stroke 80 years down the road kind of things. So that is going to have issues, and we're going to see those issues in the emergency department. So Dr. Williams here to talk to us about that. And, first I want to do is have you start off by, let's give us the lay of the land. Where are we now with the topic of NOACs, anticoagulation, and the world of emergency medicine?
So I'll answer that in one brief sentence. Well, first of all, thanks a lot for having me. It really is fun to be here. It's been so exciting to be on this ride following the anticoagulants and also the reversals now. So it really is an exciting thing. And you're exactly right that I think we found the success of these NOACs initially when they came out, which was about 6 years ago, that there was a lot of concern, well, how do they work? We don't have anything to monitor them. There's not a level, and we need a reversal. And so people sort of used Coumadin as their paradigm. Mm-hmm. Well, now 6 years out, I think people realize that, in fact, what we said initially is true, that these NOACs, or now it used to be novel oral anticoagulants, and now it's non-vitamin K antagonists, oral anticoagulants. They really are safe. They have a great safety profile. They have ease of use. They don't have the med-to-med interactions, don't have the food-to-medications interactions. And so the popularity now has really expanded. And so they are safer, but just numerically, as their impact is grown, we'll see more and more bleeds, I think. And primarily, as you said, also with people growing older, living longer, being in trauma, and they're on these medications, there's going to be a need for having anticoagulants and reversal. So it's been cool because just it was 2 weeks ago, a new agent for reversal was FDA approved. It's on an accelerated approval plan, but Portola got approval for their Andexanet. And it's interesting because they're approved for two agents, apixaban and Riva, which is Eliquis and Xarelto. But it was postulated they'll actually work for all the anti-10As, direct and indirect. That would be off-label, and we can talk about that when we get into the trials. But it really is exciting to see how things have come full circle of, look, here are our concerns. The concerns were addressed. These are safe medications, and now we have reversal. And you know what? They're not being used much, certainly not as much as anything for what we're seeing with Coumadin, because the incidence of bleeds is significantly less.
We were living in an era of very much the Wild West for quite some time with these medications, because we had all these medications out there on the market, and yet we had no opportunity, basically, if somebody had a bleed. We've had a few things out there. We talked about Kcentra and last time, and some of these medications that are out there, but really, the research showed that they're really, and the experience was that it really wasn't really effective reversal. So you either had nothing, completely nothing, or hopefully something happens by throwing these types of things at FIBA or whatever at these bleeds or complications or trauma. Up until this, and we'll talk about the research. Where are we in terms of the NOACs with the reversal, potentially, quote unquote, loose quotes, reversal agents that we had out there? Where were we before this most recent approval?
Yeah, so where we were 6 years ago and where we are now are completely different. where we were back then was even thinking that Coumadin has reversal agent really was sort of a non sequitur, because basically it had a factor replacement with vitamin K, and then Kcentra came out. And so even that, it's not a reversal agent, it just replaces the factors that weren't there. So if you fast forward now, 6 years later, it's really changed dramatically. Yeah, we still have Kcentra, and that is indicated only for Coumadin. Before it was used off-label because we had nothing else for these newer agents. And again, even though the incidence was low, it occurred, and when the bleeds occurred, sometimes it was critical. So in 2015, Boehringer Ingelheim, which is Pradaxa, they had their reversal agent of Praxbind. And so that was a cool agent because that's an antibody directed precisely to Pradaxa, and so it takes it out. And now, 2 weeks ago, as I mentioned, Portola had their medication approved, and that's Andexanet, and that's indicated for reversal of Eliquis and Xarelto, or Riva and apixaban. And so the cool thing is now we have something that we have both phase 3 and phase 4 level trials that have shown this stuff really does have an impact on the anticoagulants, and it really can take them out of the picture. And so the important thing is still that even though it's exciting this is to have the reversal agents, it still doesn't change the underlying pathology that the patients have. So I think the expectations have to be tempered just a little bit. It does take these agents out of the picture so we don't have to worry about them anymore, right? So if you have a patient, you can effectively say, okay, they're not on an anticoagulant because I've given the reversal. But it's still going to be a 75-year-old patient who has CHF, who has survived the heart attack, who might have AFib.
Yeah, they still have the reason why they need it.
Right. Oh, and by the way, they have a AV malformation in their gut, or they had a trauma, or, you name it. So that's, I think, one thing. It's really exciting, but you have to temper it because, by and large, the people are on these medications because they're sick to begin with.
Yeah, that's true. I mean, that is something we talk about when we're talking about these things, is understanding that I need to reverse this for this reason, but here's the issues, the potential issues. One, we're going to potentially uncover. We are going to uncover that whole reason you needed to begin with and potential of complications from that. So, and even with the best case scenario, you're still having some risk in reversing that. And I think there's been a fair amount of discussion among emergency physicians, other podcast areas like that, where there's concern over, the overall ineffectiveness of what we've had so far. That it was theoretical, but didn't necessarily work and wasn't perfect for what we were really seeing, which was common. I mean, clearly the two medications are probably the two that we're going to see most often with the Eliquis and the Xarelto. They're going to be by far the most common that we're going to see in the emergency department. They tend to be the ones we see a lot for DVTs and AFibs and all that type of stuff like that. And they were kind of ones that were left out without any successful reversal. And what I find a lot in hospital is the hospital tends to want to have one or maybe two of the reversals, but without regard for the fact that really most of these are targeted. So the Kcentras and vitamin Ks for your Coumadins, with the off labels, your FIBA and others like that, where we hoped they were going to work, but even then they weren't that terribly effective. Are we making progress that we may actually have something that's legitimately effective, not just Hail Mary, I hope it helps, and at least I'm protected from a medical legal standpoint because I gave something?
Oh yeah, absolutely. I think so. The FIBA and the Profil 9, we were using that only because there was nothing else. And again, that was 6 years ago. So those things, not only did they not work, but they were also thrombogenic also. So it really was bad in two regards. With these new agents, they've been really particular in how they've developed them to say, look, we're going to be targeted towards one agent or two agents, and we're going to take that out of the equation, but also they don't have the procoagulant effect also that some of the older things that we used to use would have. So that's really a win-win for us. But you're right, it's funny, the hospital administrators, they're worried about their Pyxis real estate, and they want to narrow it. And unfortunately, this stuff is so complicated. And as we talked about earlier, everybody is older, they're on these medications, not just these agents, but also antiplatelet agents. And so it really is a challenge to educate ourselves about, what's what. Some of the surgeons, as an example, they may not even know the difference of anticoagulants versus antiplatelets. They sort of think bad is bad. And that's not to be pejorative of them. It's just to really underscore how complicated this stuff is. Mm-hmm. But yeah, today we're really in a good place because I think now, if you summarize it, you can say for Coumadin, vitamin K, Kcentra. That's the reversal. For the second component, if you look at Pradaxa, there's Praxbind, and that's pretty much like a digoxin digibind. It's an antibody directly to the molecule, it takes it out. So that's the antithrombin. So then if you look at the other category of the novel oral anticoagulants, or the NOACs, that would be the anti-10As. There are 4 on the market now, actually, and so this new medication, Andexanet, that's targeted at the anti-10A molecule specifically. So really, that's the overview of what we need for reversal. So it really does. It's specific, it's targeted, and it's not thrombogenic.
Let's talk about it. Let's get into the research a little bit. I know that everybody out there right now is wanting to dig into some good, long research. That's why I bring folks like you on here, is because a lot of these research articles are good nighttime. I mean, it's as effective as milk and cookies.
It helps insomnia.
Yeah, it's as effective as milk and cookies for me for a good nap. And so talk to me about the research. Break it down. Give us the summary of the research that's behind these new reversal opportunities, and whether it's actually going to have a success, or whether this is not just another kicking the can down the road.
I think they'll have success, but there are ongoing studies. Mm-hmm. And so with any of the drugs, there are several phases that they go through, but let me focus on the phase 3 and phase 4 trials. And so I'll focus on the one most recently approved, the Andexa. They call it Andexa. It was Andexanet for the studies. The phase 3 basically looked at the effectiveness of the medication. So they looked at healthy volunteers, and they used older patients, which is actually a little bit unique. Some of these phase 3 trials, they'll use college kids for ease of use. But this, they recognized, look, the medications are used in an older population. So in the phase 3 trials, they looked at people with an average age of 77. And basically, what they wanted to see is, so how do we know that this anticoagulant is actually reversed? So we're reversing a reversal. And what they did is they looked at 2 things. One, they wanted to see how much of the reversal agent is actually, or the anticoagulant is actually in the serum after we give the reversal agent, but then how much of the coagulation cascade is actually then regenerated once the medication is given. So if you look at the factor 10A, and then if you looked at thrombin generation afterwards, that'll show you how effective these things are. So that's effectively the efficacy and safety trial. That was a phase 3. The cool thing about this stuff is that it's a decoy molecule of a factor 10A molecule. And so basically it works by competitive inhibition. It's floating around there, it's free, and so it will attract basically the anti-10A anticoagulants. I haven't put you to sleep yet, have I?
No, we're still
okay.
here.
So the anticoagulant is then competitively binds to this decoy molecule. And so basically it takes it out of the system, and so it doesn't set off the cascade. And so by blocking it, then it just takes it out of the system, and it gets back to what our goal was originally, to say, okay, we still might have a trauma, but we don't have to consider this person on anticoagulants. And we know that because it happens within 2 minutes. We don't find any of the anticoagulant, the anti-10A levels in the serum, but also we find that you're generating thrombin. So not only is it taking the anticoagulant out, but it also confirms that my coagulation process now is restarted again. And that happens within 2 to 5 minutes of starting this IV bolus, which is really cool.
So you're basically, we've created a factor 10A sweeper.
Yep.
Well, inhibitor, sweeper. And where are we with, do we have any information yet on how it's working in real life? I mean, we know relatively, quote unquote, healthy. We know the lab, but unfortunately we work, in emergency medicine, we work in real life. So what is it, do we have any experience knowing how this is going to function with that elderly patient who walks in with the head bleed?
Right, and so that's exactly right. And so that's a phase 4 trial, and this was published in the New England Journal about a year ago. And that's exactly what they wanted to see, is how can you and I, when we have an elderly patient on one of these anti-10As, how can we treat them? So the phase 4 had a criteria to say a patient comes in with a life-threatening or a major bleed. And so that's, to step back just a moment, that's an important criteria, because a lot of these agents, they may have a bleed, but often you can wait it out.
Right.
Because they're so fast on, fast off.
And we do that for most of them.
Absolutely.
Most of the time it's a minor bleed. So like a little GI bleed, but a stable H&H, I'm going to let it ride.
Yeah. And in fact, even last week I had a patient, believe it or not, who had a subarachnoid, but she was neurologically intact, and she had had her medication more than 8 hours preceding her arrival. So even that we were able to ride out, didn't need a reversal, and the patient did fabulously well. So that's really the cool thing. So you have to understand, this is really indicated for only those patients who have a major life-threatening bleed.
Within that narrow window, therapeutic window.
Right, that's the group that we're talking about to give these reversal agents to. So when you have that, and that was a phase 4 study, they said, let's give them these medications, and they had 2 primary endpoints. One, it was a serologic endpoint or a biomarker endpoint to say, so what's their factor 10A activity, what's their thrombin activity? But then also, and this was significant to this trial, it had a secondary endpoint, which was the clinical efficacy. Namely, what do we care about? Does the bleeding stop? And so they looked at the patient at 1 hour and they looked at the patient at 12 hours, and they assessed what the delta was in various parameters. And primarily it was for GI bleeds. They had what their delta was for the crit, and for an intracranial bleed, which was about 50% of this population of the phase 4, they looked at what the size of the bleed was on CT scans. So they would CT it initially, CT it later, look at what the change was, and then they stratified those. Did we have excellent benefit in reduction of size, or at least maintenance of size? That is, it doesn't continue to accelerate. Is it good, or was it not so good? And the cool thing was that 80%, and this is really the key thing, because GI bleeds are okay, but intracranial bleeds are the concern, right? The key thing was 80% of those patients had excellent or good decrease in the rate of acceleration of intracranial bleed. So that was the exciting thing, that really showed clinically that, hey, we're really stopping it. Now you still have challenges, particularly in intracranial bleed, because they'll have edema, they'll have other things unrelated to the anticoagulants that the reversal agent may not be able to address. With any bleed in particular, they're going to have some morbidity. But what it did is show, hey, we're taking this anticoagulant out of the equation, and we can really treat this patient the way we normally would.
Sidebar question. It may not be in your paper, in your notes and things. You probably may not have been asked, but I have had 3 patients with meningitis this week. I don't know what the heck's going on, but we've got 3 meningitis this week. And I still remember when I first started at my current hospital, having somebody come in that needed a lumbar puncture, and they were on an anticoagulant. It wasn't one of the 2 we're talking about right now. And we have this chart that says how long you have to wait. And I think the one that I was on was 72 hours plus, before you can actually do a lumbar puncture. Has there been research, studies, findings? I'm sure it's going to be off-label, because I bet that's not a direct endpoint they were measuring, for if I need diagnostics. So they don't have a complication, but I do have an urgent need for diagnostic, coming in with their headache and neck pain, fever, CT scan, head is negative, but now I need a lumbar puncture on this patient to rule out meningitis. How long after I administer this can I consider a lumbar puncture with these medications? And then, after that, we'll talk about how long then before I can restart the medications to get them back, preventing what I was trying to prevent before.
Right. That's really getting it down to the nitty gritty. We really want to have these things, basically turn them off, turn them on again if we can. So in the setting of a meningitis, basically that fits into the second category. So there's the bleeding reversal, and then there's the non-bleeding but has a need for an emergent procedure.
Yeah, procedure,
whether it's a lumbar puncture or cholecystectomy, you name it. So Andexanet doesn't have that indication, so it would be off-label for that. If you look at idarucizumab or Praxbind, it does have an indication for the non-bleeding emergent procedure case. So you could give it to that patient, you would have reversal, do your procedure, and then presumably you have hemostasis. I've not seen you done a TAP, but I'm pretty sure you have hemostasis after your TAP. You can restart them on therapy.
Yes. Well, at least 27% of the time they're not bleeding to death. Yeah.
So again, it would be off-label, but it really goes to the point where, just like we have to risk stratify these patients to decide who's going to be on them, we have to risk stratify when we need these medications to reverse the anticoagulants too. So in something like that, my personal preference would be just give the antibiotics, because it's really not going to be worth it if you look at the risk benefit of the meningitis treatment versus withholding the anticoagulants and potential consequence of them having a stroke or other sequelae. For me, that would favor just hold the procedure and give the antibiotics. If it's a cholecystectomy or something, different scenario completely. So again, the idarucizumab, that has the indication for non-bleeding but urgent procedure. The Andexa, it has clinical data but not the FDA indication or approval for that.
Where are we going from here? I mean, there's still clearly some work. We're finally now have something for almost all of those that we're seeing out there right now. What are the next steps, and where do we go in the future?
So I think that the first term short step is going to be still more data collection, and that goes with registry. So we're going to have some registries for these patients. So in addition to you and I just talking and sharing experience, we can really get large numbers and decide what really is the best practice. And by getting the large numbers, then we can really narrow down some of these groups who are receiving it, who needs reversal and who doesn't, and then what the outcomes are. I think that's the short term. The other cool thing I think that's been shown in the past 6 years is, although everybody really wanted to say, I want an INR for this new agent, that we don't need that. We don't have to have an anti-10A, because we find that they really are short on, or fast on and short off. It's really what we love in emergency medicine, right? It's like fentanyl. Works immediately, and it's all fairly quickly too, but you still get the patient what they need. So that's the cool thing. I think going down the road, the next steps are going to be to get more clinical data to see what the outcomes of these medications are and how it really affects the patient's outcome, because that's the holy grail. I think that the most recent study did that in a large degree, because as an example with the ICH, it decreased the expansion of the intracranial bleeds in 80% of the patients in a good or excellent group. But we still have to get more data. And, remembering these are really sick patients, so you're looking at so many comorbidities, you're looking at what their renal functions are, you're looking at all the other medications, what their etiology of the bleeds is. That's really going to be a challenge, but I think that's the exciting thing about narrowing down some of these patient populations.
That's going to be the big challenge also, so we have such a growing elderly population with the baby boomers, that this is going to be big, really big for the next 20, 25 years as that population ages, and then we're going to have a drop off in, that post baby boomer generation where we had, the lower birth rates in the United States for a number of years. So it's going to be huge, because we're going to have a number of patients on this as we get those patients that are dealing after strokes with AFib, with DVTs, with PEs, with cardiac related issues. The numbers are going to be so high. And what amazes me is what we've done in basically within a decade. We've had a new set of medications, or a new generation of medications come out with no opportunity or with no reversal. So it's basically, good luck, don't fall. And now we're getting these medications that are getting fast-tracked for reversal, and so far have been pretty, not terribly successful. Theoretical potential for success and hopefully some benefit, but nothing that is going to be, proven, especially with regard to the increased risk of thrombotic events because of those medications. And now we have this there. I mean, the amount of evolution in one area so quickly, what typically would have been 20 years, 20 plus years, is now, an entire generation within 6 years, 8 to 10 years, maybe. It's really amazing. But the challenge being that with it fast-tracked, something we're not typically used to in the United States. We're used to things, the rest of the world has truly hashed out everything, and then we adopted the United States after they've basically the phase 4 and afterward trials were the rest of the world, and then the U.S. adopted after success there, but we're seeing things coming quicker here. And, so we're going to be collecting that data on the risks and the benefits and results and outcomes, and, and then putting that all together. What messaging do you have for the physicians out here, the physicians, nurse practitioners, physicians assistants that are listening, that are going to be dealing with these sorts of things, and knowing that things are changing so quickly with regard to our anticoagulant approaches out there?
Yeah, so the main message, I think, is, number one, have confidence when you're seeing these patients on the medications, meaning the novel oral anticoagulants or the non-vitamin K oral anticoagulants, because they really are fast on, fast off. And it's like everything else, right? needs time for you and I to develop a comfort level with prescribing them or treating the sequelae if there's a bleed. Because by and large, the bleeds, when they occur, they're either a nuisance bleed or it's something that we can wait out. It's really a small group of patients who have the intracranial bleed or have a GI bleed that requires reversal, meaning they have significant effects from that bleed, or they're deteriorating quickly and they need to be acted on quickly. So that's the number one thing. I think have confidence in it. So then what do you do about that small group that does have the bleed? To summarize it again, I sort of think the answer is this. If somebody's on Coumadin, get their INR. If it's a severe bleed, Kcentra will help, and you dose that based on what the INR is and give them the vitamin K. Next, if they're on Pradaxa and they have a severe bleed, give them idarucizumab or Praxbind. And that's an antibody that takes it out within 2 to 5 minutes. Again, it doesn't do anything about the underlying bleeds, but it takes that medication out of the equation so we can treat it. And then lastly, now with this recent FDA accelerated approval, which means they're still collecting data, Andexanet has an approval for reversal of the Riva and Apixa, or Xarelto and Eliquis. Will it work for the other anti-10As? It may. It's off-label. It's not FDA approved, and I think they'll probably collect more data. Because that'll be the cool thing, right? If we can say, hey, look for fondaparinux and Lovenox, and Savesa, and Eliquis, and Xarelto, that Andexanet will take care of all of that, that'll be really cool. Now, there are some different dosing adjustments that you have to make based on when the patient last had their medication, what the dose of the medication was, but that'll be really cool. I think that'll simplify things if they're able to expand that indication down the road.
Yeah, interestingly, the Andexanet, Andexa first real publication, the NEJM, in November of 2015. So, we're still 2.5 years of evolution for approval, and that's considered the expedited approval from the FDA. One thing I didn't ask, and, just so we've got our procedure. Granddad needs his gall sac taken out. And so we take him up to surgery, and we reversed his NOAC and take him to surgery. Have the trials so far shown how long this remains in the system? Because that's one of the things with, so let's say we're dealt a lot with opioids. So we know that really after our dose of Narcan, we're going to have about 30, 45 minutes that it really doesn't matter what you give. It's going to block that. So how long is this going to stay in the system and block my next dose?
That's a really nice analogy, too, because you want to say, look, is the half-life of this shorter or longer than the medication that we're reversing, and do we get a rebound? And in fact, the studies really haven't shown any rebound effect. And so that's a cool thing. So again, if you look at what are the 10A levels, you don't get any rebound or prothrombotic effect once these anticoagulants wear off. So basically, again, it just takes that medication out of the system, it sweeps it, as you said, and then you can deal with the issues that the patient presents with. The cool thing, though, going down the road, speaking about the older guy who needs his gallbladder taken out, is so when do you start him on medication again? And that's really the yin and yang of the internist, cardiologist, emergency physicians versus the surgeons, because their main concern typically is, I don't want to have a bleed after my case because I get the ding for that on my metrics. But you and I think were talking earlier and said we both have seen, unfortunately, whether the medication was withheld too long both pre-op or was held too long post-op, and then the patient comes in with a stroke. So that's the worst scenario, so we want to avoid that. So part of the education is, just as the DOACs are fast on, fast off, these reversals also are fast on, fast off. They start within 2 to 5 minutes. You have a measurable decrease in the availability of the anticoagulant, so you're really turning it off immediately. And within really 12 to 24 hours, there's complete washout. And you don't get any rebound effect. It's not thrombogenic. So that's really a cool thing. So what it says is then once you have hemostasis, and presumably they're not going to close the skin until they have hemostasis in the setting of a cholecystectomy, that they can start that patient back on the anticoagulants. Because remember, they still have those comorbidities that put them at risk for the stroke for the AFib.
And now we're going to increase those by putting them in the hospital relatively immobilized.
Absolutely. So that's a key thing. And so I think the more experience we get with these medications, the more comfort level everybody's going to give and have. I think, it was unbelievable 5 years or so ago when these agents first came out that we would think, you had a subarachnoid and you didn't have to reverse it. But basically, one of the most important questions is, number one, which one is it?
Right.
So is it a direct antithrombin or is it direct anti-10A? And then the second most important question is, when was your last dose? Because that'll help determine how fast this washout is. And then also you want to know what the renal function is of that patient, because that also has an impact on how fast the medicine is going to be cleared or not. So those three questions, I think that's going to give you a lot of confidence. And then for those rare patients who need it, then you have, I think, all three categories covered with a reversal agent, which is really exciting. But again, most importantly, make sure you get these patients back on therapy, because remember, heart attacks and strokes, those are still the number one cause of death and number one cause of morbidity in the country. And I really hate seeing patients so worried, or the doctors so worried about a bleed that they withhold these medications and then they come in with a stroke, which was completely avoidable.
Dr. Jim Williams talking to us, our 2018 update on the current state of affairs of anticoagulation and, more importantly now, reversal agents. And I'm sure we'll get more coming up.
More to follow, absolutely.
I'm sure there's going to be more changes and things, especially as we get that real world data in terms of how it works and the benefits and impacts. And that is one of the things that I want everybody to remember, because you mentioned it, and I want to stress it, that importance of which medication is it, what are the characteristics, what's that half-life, because the two most common that we're going to see really do have a pretty quick half-life clearance. And so if you have that elderly patient that is found in the floor in the morning and has a head bleed, if their last dose was 8 p.m. On a 12-hour half-life medication, they're pretty much clear already, and then it's just managing that situation,
right, and
then finding out. And the challenge I see, though, is a lot of times that they're altered enough that they can't remember when they took it, and the family member is like, I don't know if they took it. I think they took it. No, I can't tell. They didn't have it sorted out, so sometimes that's difficult. But that is, important information, that we have the medications now that are a little bit faster off, which is good for us from emergency medicine, but is bad for patients who aren't very good at taking their medications. Forget a dose here and there. And
true. But the good news is now we have some reversal agents, and I think that'll really be a game changer for this. I think it's going to help people understand that, hey, the anticoagulants, first of all, the NOACs are safe, and I think give the late adapters a little bit more confidence to use them. Mm-hmm. And for me, I'm really excited about that, because my number one concern about the anticoagulants with Coumadin is head bleeds. I'm just tired of seeing head bleeds. Nobody should be on Coumadin now unless they have a mechanical heart valve. And hopefully having these reversal agents, they're not going to be used much, but it'll just give people a little bit more confidence that in that rare case you need it, they're there.
I think Coumadin, that person coming in with a warfarin with their head bleed and INR of 7.5, and basically the water from the sink in the patient's room has more clotting ability than their blood does. So it's neat the times we live with the new medications, as well as what we can use in the emergency department when there's complications, either related or not related to those medications. So Dr. Jim Williams, give us some information on how to get in touch with you if folks have more questions, or if they are the type out there that really want more research to read and look into and talk about, there just wasn't enough here and they'd like another 800 pages of data to pour over.
I'd be happy to. Sure. My email is drjmwilliams@gmail.com, or if you want to call or text me, my cell phone is 210-710-5451. So if you can't sleep at 3 a.m. and you need some data to help you get to sleep, and I'm in a night shift, I'll be happy to help you out.
That is bold. Jim Williams giving the cell phone 1,000 downloads a day, and he's going to put the cell phone out there. Good luck with that.
Anything for you and our readers.
Yeah, everybody go ahead and text Jim. Let him know how he's doing, and that you appreciate his information. As for me, you can email me at youreverydaymedicine@gmail.com. That's youreverydaymedicine@gmail.com. @everydaymed on Twitter, also our ACEP Frontline page on Facebook as well. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.